Welcome to the series, Perspectives on Step Therapy in Oncology. My name is Rafael Fonseca, and I am a hematologist at the Mayo Clinic in Arizona.
I'm Jacob Kettle, oncology clinical pharmacist at the University of Missouri.
Kristina, Director of Navigation for East Florida Division for Sarah Cannon.
And I'm Lee Schwartzberg, medical oncologist and medical director of the West Cancer Center in Memphis, Tennessee.
Well, thank you for joining us. Today, I would like to take this opportunity to discuss some of the conceptual aspects behind step therapy. Perhaps we can make some comments about how this is applied in other fields, say with antibiotics or antihypertensives. Perhaps talk a little bit about how this is being considered, stepped up, the scalability of it, how it applies to rapidly changing areas of medicine, such as, of course, oncology, and that's what we're here for today. But why don't we start with you, Lee? What, just for our audience, what is step therapy?
Yeah, step therapy refers to the process by which insurers mandate a particular type of therapy for a particular disease at a particular time in the course of that therapy. And it's called step therapy because if you're said drug A has to be done, that's step one. And if the patient fails that drug, whatever the definition of fails is, which is something we should discuss today, is then you can use a different drug. Now, generally, step therapy is performed because it's a cost-saving initiative, and insurers want to save costs. We have a lot of new drugs on the market, which is good. Many of them are expensive. Sometimes new drugs and expensive drugs in various settings are not better than older drugs, and so that concept really comes from the evidence base and trying to say this drug is as good as this drug, and we're going to ask you to use this one to save cost in the system in terms of medication costs.
Well, and of course we're here because we are considering how step therapy will impact oncology. Can you tell us a little bit about what the concerns are with step therapy? Why are we having this conversation?
There's several issues, obviously. Step therapy initially, like Dr. Schwartzberg said, is intended for a cost reduction measure. But we find that as the step therapy process goes along, that we're incurring delays in treatment. And I think that is one of the big issues. And a lot of the times it's affecting our patient care. That's issue number one, delay in treatment. Number two, so a lot of the times it's the failure. When we fail and when we discuss it with oncology, failing a lot of the times is either severe toxicities, which a lot of the times are life-threatening, or disease progression that is irreversible. So I think that is the big concern as to why step therapy truly for oncology patients can be fairly detrimental.
Thank you. And Jake, of course, there's science that backs the assertions and the frameworks upon which, we would want to have the best possible step therapy. Of course, I think the uniqueness of oncology is a little bit different, and I know you have some thoughts about, one is how this is coming to be in oncology and the scalability of step therapy. Maybe you could tell us something about that.
I think a couple of things. First, I think we're all fairly on board with the concept and the need for some type of structure to kind of effectively utilize what's, limited resources. So we understand that concept, and I think P&T committees for decades have operated in a hospital level of making some of these decisions. I think one of the first challenges is just scaling that to much broader scope, to where we're talking about, tens of thousands, millions of lives under the umbrella of a step therapy policy. That's, when you're that far removed from the decision on the payer side and to the bedside, where the gap is that wide, I think that creates some issues. So while things on a micro level may be attainable, I think it becomes more difficult when you try to scale that much larger. I think the other challenge you've already spoken to is we are in a very dynamic period in time. The landscape in oncology is rapidly shifting. And I think it is a very daunting challenge when we start to apply those concepts that have been effective maybe in hypertension or use of antibiotics, some of those disease states which are, by comparison, relatively static, applying that to our world of oncology, which is rapidly shifting and changing. So I think, in part, that leads to some of our frustration from the provider side and clinician side, when we feel so far removed from the situation, from the decision maker, rather than it being a local decision. And also maybe we're abreast of new data that just hasn't taken enough time or had enough time to work its way up the chain through and change the insurance policy. I think that those are the situations we deal with that are quite frustrating.
You know, we'll agree it's obviously a challenge, and in oncology, things can change so rapidly. So in my area, in multiple myeloma, you know, we go from one ASH to the ASCO, and every 6 months there's something new. So I used to say tongue-in-cheek, and this is not you know, formally criticizing EBM, but I used to say EBM is a luxury of medical fields with little innovation, because you could do the, you know, atrial fibrillation clinical trials with tens of thousands of patients, and the principles stand. But oftentimes we're forced now, in a positive way, to make decisions about care based on 300 patients randomized in a phase 3 clinical trial. So we don't have necessarily the robust data as you would have, say, for some of the things with atrial fibrillation. But there's perhaps some examples where this has been tried, and we have applied this for some time without necessarily knowing in step therapy, antibiotics or antihypertensives. Maybe let's expand a little bit on that, on how that might work.
So obviously, in the nursing aspect, it's something that has kind of pounded us innately, that you start with the lower cost drug first, expose the patient to that, and then, you know, if hypertension isn't controlled, well, you know, kind of touching on that one, then you're going to either increase to, you know, medication B, like Dr. Schwartzberg mentioned, or in addition, you know, compound and do 2 medications in order to be able to protect the patient and get to that desired outcome that you have. But going back to with oncology, that's very different. So, you know, you're diagnosed with, say, ovarian cancer. If we treated you with medication A and that didn't work, that means that your disease has progressed. So now is incorporating another medication beneficial, or have now we, you know, kind of set that patient back by not starting them on a medication that we know could have effectively treated them from the very get-go?
And that's really the fundamental problem with step therapy for therapeutics in cancer. The severity of the disease, the fact that the first thing you learn as in training in medical oncology is that your best shot for treating an advanced cancer is the first shot. Mm-hmm. And you don't have the luxury to fail, because failing there can mean life-threatening or death. It's that severe. And so we really have to, our principle, the way we learn how to treat patients, is use the best therapy. And the point you made about the change makes it difficult for an insurer who is managing not just cancer, but every disease across a huge population, as you mentioned. They can't change their guidelines fast enough. We have trouble keeping up with the changes. And even when we're doing one field or a couple of fields, very difficult, very complex. And that means that we're going to be at odds with what the step therapy was based on a guideline that perhaps was last reviewed 5 years ago, just from practical perspectives.
Well, and the guidelines, it's interesting that you mentioned that. You know, a lot of our practice in oncology is based on NCCN guidelines. And even NCCN guidelines give you kind of a broad scope as to, you know, one, you know, they give you option 1, option 2, option 3 is 1 and 2, or 1 and or 3, you know. And so when you get into stuff like that, and now you have an insurance company and that not necessarily is an expert in oncology, and now they have to decide, okay, well, there's in essence 8, 9, 10 choices for treatment options, and, you know, so logistically they're going to choose the one that is going to cost them the less, which may not necessarily be in the best case for the patient.
You know, the selection of those choices oftentimes comes down to the specifics of the patient, the comorbidities, prior experience, even things like whether they can drive to a treatment center, right, an oral versus a parenteral type medication. So it gets really complicated because guidelines that we all agree try to distill to some simple form, best practices, still have to deal with the real world, so to speak. Speaking of the real world, it sounds like this is even in the eye of legislators across the nation, right? So what do we know about that? What are states doing, and where does this stand at this moment?
So to make the waters even muddier, different states have different bills that have been passed to protect their constituents. So currently, right now, there's 19 states that have actually made amendments to the actual CMS step therapy policy. I'm from Florida. Florida is not one of them. So not only do we have to see what the actual state policy say, but then on top of it, you've got the federal policy. So I think it makes it even more complex and really muddies the waters as to, you know, it's not a standard one size fits all. And then you've got the state issues that also come into to play.
Right, and these policies that the 19 states have enacted in general have been around streamlining the appeal process for step therapy. So they don't say you can't do it to the individual insurer, but they do facilitate a process that makes it easier to get a change, which is really the issue for our patients. We don't want to delay days, weeks, sometimes months till we get a decision. There is no federal policy around this as of yet that I'm aware of for managing that length of time or the appeal process across all insurers.
And I think that's maybe the main ask from our standpoint as clinicians. I think it's being able to be nimble enough to apply our clinical expertise to the patient as well. I think I'm a huge advocate for evidence-based medicine, but I think its main limitations, it doesn't allow for the application of your expertise as your experience, and it doesn't really allow for, well, frankly, we have so many, every trial we see creates 3 new questions that demand more trials. We don't simply have enough people to do all the trials to give us enough data, and I think those are the gaps where your clinical expertise need to fill in, and I think that's the main ask from our side, is we want to be able to quickly adapt. If we do have someone that has a need that falls outside of that step therapy, we want to be able to incorporate our knowledge and experience to get them quickly and efficiently treated. And I think one of the greatest gifts we have in oncology right now is just the ability of choice. There are, like you said, in the NCCN guidelines, many cases you have 3, 4, 5 plus different options to pick from that are all considered medically reasonable. And you brought up oral therapies versus IV therapies. Sometimes that's a very big distinction for a patient. Do we want to be forced into a box where a patient is the type that may be miserably compliant with an oral therapy when an intravenous or parenteral route may be much more conducive to their compliance, or vice versa? Those are kind of discussions that'll really take away our ability to apply those unique features to patients. I think that's one of the biggest negatives.
Well, and I think kind of talking about the access to care aspect to effects, and that's not something that necessarily, when the decision for the medication is being kind of pushed down from the pharmaceutical company from the insurance company is, access to care. Sometimes they'll say, you need 5 days of G-CSF support versus 1 Neulasta. They don't take into consideration the patient's just barriers that they may potentially have. Some of us that deal with rural America, to drive 2 hours to get a shot that, could potentially have been given in just 1 dose versus 5 to 7 doses. So I think that's another one that we need to kind of address a little bit.
Yeah. It's ironic that we live in an era where patient-centered care we all agree is important, and that shared decision-making is important between the clinician and the team and the patient. And step therapy sits outside that decision, and we don't have an easy way to incorporate it into the decision. So that creates conflict for us. It creates conflict for patients. Do you have my own best interest at heart if you have this third party that's telling you what to do? And cancer patients don't need that. They have enough concerns anyway. The fear is real, and to hear that they may have to get a different type of therapy than what you initially prescribe is disconcerting.
One of the things we've realized is that obviously this could be applied to supportive therapy, which may be just as important and essential to be able to complete therapy, such as would be with an antiemetic. But of course, the intensity of this conversation will get much higher when we talk about the primary therapy of the tumor. I recently had an opportunity to review close to 8,000 cases of myeloma. And what we found is with each line of therapy, there's a significant attrition. We looked at the non-transplant candidates. We found that at every line of therapy, we had a 50% attrition. So to your point, the first shot is your best shot at providing durable disease control. So I want to thank you for your comments. I think we've covered a lot of very important aspects of step therapy, and I look forward to continue the conversation.
Thank you.
Thank you.
Thank you.